Dr. Elvis Oyugi is a medical epidemiologist who is currently the HIV prevention lead at National AIDS and STI Control Program in the Ministry of Health, Kenya. His main role is to coordinate implementation of HIV prevention program within the status neutral approach. He collaborates with stakeholders to improve coverage and utilization of HIV prevention interventions in general population and key populations, and enhance partnerships in HIV prevention. So Dr. Yugi holds a bachelor degree in medicine from University of Nairobi and a master's of science degree in applied epidemiology from JKUAT. So we are privileged to have him today. So Dr. Elvis Oyugi will be able to take us through the status HIV testing and care, and we'll be happy to have you also as one of the panelists. Dr. you can take it up once you are ready. Thank you.
Thank you, Kennedy. I was just reaching out to Dr. Rose Wafula. As you are aware, we are commemorating the World AIDS Day today, so she's out, but I've shared the link with her on WhatsApp. So when she joins, we can give her an opportunity to be able to provide remarks. So thank you for welcoming myself, Dr. Jonah Onensia, and Dr. Rose Wafula to this webinar today. Today we'd like to talk around the shift, to status neutral approach to HIV service delivery, and then we'll also be able to update you on the plans around transitioning to three-test algorithm for Kenya, and also talk about pre-exposure prophylaxis and other combination prevention methods. So this would be the outline of the presentation. I'll present the first half, and then Dr. Jonah will present the second half. So we'll go through the Kenya HIV estimates for 2023, do an overview of the HIV testing services, then briefly talk about status neutral HIV care and service delivery, the HIV 3-test algorithm, which is, of course, is the direction that Kenya is taking as from the year 2024. Then combination HIV prevention, finally event-based pre-exposure prophylaxis. So looking at, let me just have this on. Yes. So looking at the HIV estimates for the year, Kenya currently, in terms of prevalence, Kenya's prevalence is 3.7%, and this has, of course, reduced from almost 13% over the last 10 years. And looking at distribution of HIV burden by sex or gender, it's actually higher in women. It's almost, actually, it's like twice, 5.3% in women compared to 2.7% in men. But again, looking at the distribution in terms of the age groups, the burden is higher among persons 15 to 24 years of age. This is basically adolescents and young people. Now, when you extrapolate to include the age group 15 to 34 years, then the burden moves from 41% to above 60%. While between birth and 14 years, which is basically children, the burden is 20%. So it simply means that in terms of targeting of interventions, then we really need to emphasize on the adolescents and the young people. So you can actually be able to see the figures there. When you look at the prevalence by county, and especially looking at the leading 10 counties, you can see Migori is the leading with 15.2%, followed by Homa Bay, then Kisumu, Kisii, Siaya, Kwale, Nyamira, Trans Nzoia, Bungoma, Elgeyo Marakwet, and Mombasa. That's the leading 10 counties. And in terms of burden, of course, the lowest burden is recorded in the northeastern counties. Now, looking at the UNAIDS target, which is the 95%, 95%, 95%. So the first 95% is around awareness of HIV status, especially for those living with HIV. And the second 95% is around linkage and adherence to treatment. And the third 95% is around viral suppression. So we've been able to attain the first two 95%. So we have 97% in terms of awareness of status, and then 97% in terms of those enrolled on care, and then 92% for viral suppression. So we still have a lot of work to do, especially so that we can be able to push the 92% to also cross the 95% barrier. And looking at the distribution of the estimated new HIV infections by age and sex, I had already spoken around this. So this basically tells you that the burden of HIV, actually 80% of it is in those who are aged 34 years and below. So very, very critical for targeting of intervention. Overview of HIV testing. This is data from October 2022 to September 2023, and it provides absolute numbers. So the blue graph is total tested, while the yellow the orange bar is total positive, and then there is a trend line, a gray trend line, which outlines the positivity. And positivity generally has been declining over the last 3 years, and of course, positivity is affected by the burden. So as the burden reduces, then of course the positivity will also come down. But we definitely need to expand or to enhance coverage for testing to ensure that as the burden reduces and the positivity also comes down, then we are not missing out on any positive cases. So the HIV testing services package that we currently implement in Kenya for the general population, the recommendation is that general population should be screened every 2 years using the national HTS eligibility screening tool and the national HTS algorithm. Then for key populations, the recommendation is to retest every quarter. But of course, there are also discussions and recommendations that are being proposed by WHO. Currently, we are doing retesting quarterly, but there are recommendations by WHO that where the key populations are able to access prevention methods adequately, then the retesting can be done on annual basis. For vulnerable population, retest biannually. Then where there's a negative partner in a discordant, a negative partner in a discordant couple, then the negative partner should be tested at initiation of ART for the HIV positive partner and retested at 6 months. And then once once the positive partner achieves viral suppression, then the negative partner should be retested once a year, as long as the positive partner has attained viral suppression. For pregnant women, they should test in the first trimester or first contact, then retest in the third trimester and during labor and delivery. For breastfeeding mothers, you should test at 6 weeks after delivery, 6 months, then every 6 months until complete cessation of breastfeeding. Now, persons who had the most recent risk of exposure to HIV, which is less than 1 month, once they present to you, test at initial presentation, and then retest at 4 weeks, 28 days. For negative clients, retest at month 3, after which the usual guideline should apply. And the guideline is now, of course, depends whether it's a key population or general population. Now, where there is STI symptomatic patients or patients with symptoms suggestive of acute HIV, then test at initial presentation, then retest at 4 weeks also. Then if negative, retest at month 3, after which the guidelines will apply. Now, for individuals on pre-exposure prophylaxis, you test before initiation. So at initiation of PrEP, you test. Then you retest after 1 month. Then after that, you retest every 3 months. Status neutral HIV care. So the world is shifting from the targeted HIV testing for case identification to status neutral approach to HIV care and service delivery. And this emphasizes on testing for HIV prevention, and it involves caring for a person as a whole using what is called a one-door policy. So this means that irrespective or regardless of your HIV status, then you can be able to access prevention and treatment services in the same place. So currently, of course, we know HIV, those who are living with HIV receive their services separately in the comprehensive care clinics. So status neutral approach is basically around bridging that gap between being HIV positive and being HIV negative, and being able to provide the services at the same place, regardless of your status. So this optimizes the quality of health because there's continuous engagement of persons regardless of the HIV status. Remember from the previous slide, we've discussed the guidelines around frequency of testing. So, for example, whether you are, if you are negative but you are on pre-exposure prophylaxis, there is that continuous engagement of between you and the healthcare provider, which of course culminates every 3 months when you get back to the health facility for drug refill. The entry point for a status neutral approach is a HIV test. So if you're negative, then we don't just say, okay, fine, you're negative and you can go. No, you are also, put on prevention methods. Prevention methods include pre-exposure prophylaxis, include condoms, and there's also the social support, which includes mental health support. There are those who could be negative, but they are, injection drug users. They're also linked to harm reduction, services and so on. For those who test positive, they are offered treatment, and they are continuously engaged to ensure there is adherence until they attain viral suppression. So once they attain viral suppression, then there's this strategy of U is equals to U, which is undetectable is equals to untransmissible. So those who have undetectable viral loads have very, very low chances of transmitting the virus. So the whole person approach addresses, the social determinants of health. So we're able to, discuss issues around housing, transportation, feeding, and so on. With all clients, regardless of their HIV status, and integration of services for both HIV positive and negative then improves efficiency of service delivery and rationalization of the use of resources. Then this approach leads to improvement in access to both prevention, services for those negative and treatment for those who are positive, and it reduces stigma and therefore reduces HIV transmission, because those who are negative adhere to prevention methods, and those who are positive, get virally suppressed and have low chances of transmitting. So this is a schematic diagram of a status neutral approach. So that's a client, you receive HIV testing services. You either reactive or non-reactive. So if you're reactive, then you are enrolled on ART and engaged in HIV care, achieve viral load suppression, then the zero risk of transmitting HIV. And while virally suppressed, there's also the reduced morbidity, mortality, reduced chances of complications and the progression to advanced HIV disease. Then those negative, but of course, there are those who are negative but have a higher risk, of exposure. So the risks are usually assessed by the service provider, and those who are at high risk, are enrolled on PrEP, while those on lower risk, those with lower risk are provided other prevention methods. So our UNAIDS 95 target, where you mentioned we are at 97%, and 92%. But as we move towards meeting those targets, there's need for us to enhance both prevention and treatment services. So testing for prevention, so that people who are at risk of contracting the disease are able to access effective prevention methods. And then there's also testing to link and re-engage in treatments. Basically, this is what I've been explaining. So for status neutral approach, where do we start? So it's important to identify the facilities or services with the biggest potential to implement, and you look at how the services currently are designed, and see how to do integration, so that this integration of HIV testing, prevention, provision of the prevention methods, and ART. And then there's need to be able to involve the community. So there's, of course, the community testing, community index testing, default tracing, and so on. And also thinking around which testing approaches to be utilized within service delivery points. Of course, for example, for key populations, there will be social networking, and social networking. This can be testing both within the facility and even community, when we go for outreaches, and all those that turn positive are supposed to be linked to treatment, while those that turn negative are linked to prevention and this continuous engagement. Monitoring and evaluation component. So as NASCOP, we continuously, revise reporting tools, revise the DHIS to the KHIS to ensure that we're able to collect data on some of this new progress. So, for example, we've been able to revise our tools to be able to capture reporting on pre-exposure prophylaxis. We are moving towards assigning a national unique patient identifier, the NUPI, to anyone who's going to be able to access HIV testing services, and that is usually very important for tracking, especially for mobile population. And then we are also looking at how to upscale PrEP access, enrollment, and retention for those negative and at high risk, and we continually adopt quality improvement to ensure that we address the gaps as we find them. So I'll quickly then move to the WHO guidance around HIV diagnosis or HIV testing. I think we basically know that WHO recommends pre-qualified serology assays, and as a country, we mostly been doing the rapid diagnostic tests. And to obtain WHO pre-qualification, an assay should demonstrate 99% sensitivity and 98% specificity. But these are just aspects of validity of a test kit. So there's the aspect called positive predictive value, and positive predictive value is the probability that if you test HIV positive, then you truly have the virus. So WHO recommends that a test kit should have a positive predictive value of at least 99%. So that means if 100 100 people are tested and all of them are reactive, then there's only a chance of missing one person and being able to identify 99. So an ideal HIV testing algorithm should be verified before rollout. So it should be verified, that is within the country. Then it should not share the same false reactivity. So I'll explain that. Now, false reactivity usually tends to happen among tests that are produced within the same company. So it is recommended that if we are having an algorithm-based assay that has 3 test kits, for example, then those test kits should be manufactured by different companies to avoid the problem of false reactivity. So the problem of false reactivity then means that if you're doing the first test and the second test, and both test kits are from the same company, then there's a higher chance that you might be able to get false positive or false negative results. So the algorithm should have more than 99% PPV, and currently WHO is recommending that countries need to move to a 3-test strategy from a 2-test strategy. Kenya has been, currently we've been implementing 2-test strategy, starting with the determine kit, then moving to the first response. But currently the recommendation is that we should have the first test, which is A1. So A1 has been determined, then A2 has been first response. But now there's A1, A2 and A3. So A1 has the highest sensitivity, then A2 and A3 has the highest specificity. So at A1 with the highest sensitivity, then the chances of false positives. So these false positives then will be corrected by kit 2 and kit 3, which have high specificity. Specificity is basically the ability of a test to assign, to pick out a negative, while sensitivity is the ability of the test to pick out a positive. So why should we change the algorithm? Now, when prevalence drops below 5%, then the positive predictive value also will drop below 99% if you're only using 2 kits. This is also due to reduced HTS positivity that I showed in the graph. Therefore, we need to move to the 3-test strategy because our prevalence currently stands at 3.7%, which is below 5%. So with regards to the principles for selecting the testing algorithm, so I've already said that A1 has the highest sensitivity. So it will have both true positives and will also pick false positive. But A2 and A3 will then correct and rule out the false positives. So this is a description of a WHO3 assay strategy. So the service provider is supposed to perform the first test, which is A1, and the client will test either positive or negative. So if negative, then assign as negative. If positive, then perform A2. Now, upon performing A2, and then there is discordance in results with A1, then the service provider should go back and perform test A1. So I'll give an example. If at test A1, the client tests positive, then at A2, the client tests negative, then you should go back and do A1. And at that point, if the client tests positive at A1 and A2, then you'll move to test A3. So we are going to go through this. We are going to show you a diagram for the current recommended testing strategy for Kenya, so that you can be able to follow very well. So after performing A2, then you perform A3. So if positive at A1, A2, and A3, then report as HIV positive. Now, if positive at A1, positive at A2, but negative at A3, then report as HIV inconclusive and retest after 14 days. Retest after 14 days. If positive at A1 and then negative at A2, then repeat A1. Now, if you repeat A1 and you realize that the client now is positive at A1. So the client was positive at A1, negative at A2, but you repeated A1 and the client is still positive at A1. This should be reported as inconclusive and retested in 14 days. If you repeat and the client is the client is now negative at A1. So initially was positive at A1, negative at A2, but when you repeated A1, then the client is now negative. Then report that as HIV negative. This also follows for the HIV dual syphilis, the dual HIV syphilis testing. This is for the ANC setting. So the test kit A1 is dual HIV, syphilis. The test kit A2 is HIV only, and the test kit A3 is HIV only. So in this strategy, only test kit A1 will be different, but test kit A2 and A3 will be the same as for the general population. And it basically follows the same strategy as the general population. So there is need to conduct verification. I'd mentioned that. So this is something that Kenya has already done. Kenya had set up a task force to review the current strategy. The task force recommended transitioning to the 3-test strategy. And we've already undertaken the verification study, which actually happened in 2022. So verification panels were established, and 250 specimens were analyzed, and the results were already analyzed and published in a report which the ministry has adopted. The ministry has communicated the policy to transition to the 3-test algorithm. So this is what I was talking about. So phase 1, study preparations. Then phase 2, there was verification of kits at the National HIV Reference Lab. And then phase 3, there was piloting of the 3-test algorithm in 4 counties. So the task force found that with our HIV prevalence below 5%, our PPV also went down below 99%. And currently, the algorithm uses DNA PCR to resolve inconclusive results, but this is not implemented uniformly throughout the country. And the recommendation was that we should review the current algorithm and transition from 2 to 3-test strategy, discontinue the use of DNA PCR for inconclusive results. Instead, where there is inconclusive results, we should retest after 14 days. If after 14 days is still inconclusive, then retest after 3 months. Then there is also a recommendation around regular proactive post-market surveillance. So this is the recommended 3-test HIV algorithm for the country. This is the algorithm that we'll be implementing from next year. So the first test A1 is no longer determined, but now it's TRIN screen. And once you conduct the TRIN screen test, if the client is non-reactive, then report as negative. If reactive, then subject the client to the second test, which is 1 step. And upon the second test, if the client is non-reactive, but was reactive on TRIN screen test, then repeat the TRIN screen test. If on repeating the TRIN screen test, the client is non-reactive, then report as negative. If reactive, then that is inconclusive because there's disparity between TRIN screen and 1 step. Report inconclusive and retest in 14 days. Now, on the other side, reactive on TRIN screen, reactive on 1 step, then subject to the 3rd test, which is fast response. If reactive, then should be sent to the 2nd tester. If non-reactive, then that is inconclusive, report as inconclusive and retest in 14 days. For ANC settings, A1, which is the dual test, is standard Q. It has both, so it tests both for HIV and syphilis. So perform the first test A1. So for HIV, if non-reactive, report as negative. If reactive, then you follow the similar step to the general population. Then for syphilis, if non-reactive, report as negative, and if reactive, report positive and treat for syphilis. Looking at the two algorithms, the current and the one that we are transitioning to, the difference is that in the current algorithm, we've been using DNA PCR for discrepant results. So moving forward, we'll be retesting after 14 days to resolve inconclusive status. And if after 14 days it's still inconclusive, you retest after 3 months. Any inconclusive results at 3 months should be reported as negative. And I've already spoken about discrepancy among the tests, especially for tester 1 and tester 2. So if there's discrepant results for tester 1, then you need, if there's discrepancy in results between tester 1 and tester 2, then you need to go back and do tester 1 and then either report as inconclusive, or if the test status changes, then report as either positive or negative. So finally, I would like to just display a roadmap in terms of implementation for the 3-test algorithm. We've already disseminated the task force reports. We've developed the implementation plan. We were not able to undertake any trainings this year, so the trainings will begin from the first quarter of next year, and hopefully the 3-test strategy, will be able to implement towards the first quarter of next year. So I would like to stop at that point and invite my colleague, Dr. Jonah, to take us through the combination prevention package for HIV prevention, and then after that we can take any questions you may be having. Thank you, and back to you, Kennedy.
Thank you very much. Thank you very much, Doc. You've been loud and clear. We've been able to follow your presentation as you go by. So, team, allow me to welcome to you our second presenter, who is doing continuation of where Dr. Oyugi has left. Our second presenter is Dr. Jonah Onentia, who works with the Kenya Ministry of Health, National AIDS and STI Control Program, heading the HIV testing and PrEP section. He's a medical doctor with over 15 years public health experience of both healthcare service delivery and national program. So Dr. Jonah will be able to take us through combination prevention package for HIV prevention, and we welcome him. Daktari, if you are ready, you can take it up. Karibu sana. Yes, Dr. Jonah, maybe you unmute your microphone.
Thank you. Thank you, Kennedy, for that invite. And I also want to appreciate Dr. Elvis Oyugi for taking us through the 2 previous sections. And I wish to change gears so that we can be able to look at combination HIV prevention strategies that we have. Basically, we are looking at HIV prevention strategies so that we can be able to reduce the HIV incidences. And we are looking at basically the biomedical factors and the behavioral factors and the social structural intervention components that are influencing one's exposure to HIV and acquisition of the same. All these factors either reduce an individual's risk for acquiring HIV, or rather, or also improve the outcomes along the HIV care continuum. When we look at the three arms of prevention, we are looking at the biomedical, behavioral, and structural. For the behavioral interventions, these are geared towards providing comprehensive information, motivation for the clients, and even the education and skills building to help the individuals reduce their risky behaviors and also sustain the positive change. And then also the aim to increase the acceptability and demand for the biomedical interventions that we are also going to look at. The key interventions, when you talk of the behavioral interventions, include the peer education programs and also targeted information for particular subpopulations and education and IEC for those particular subpopulations. And then the promotion, demonstration, and even demonstration of these prevention methods. For instance, the use of the male and the female condoms, and also the water-based lubricants, the needles and syringes for clients who inject drugs. We also look at the risk assessment for these particular interventions, and then conduct risk reduction counseling and skills building, and also the evidence-informed behavioral interventions, commonly known as the EBI. When we look at the structural interventions, we are looking at addressing the social, economic, political, and environmental factors that will affect an individual or even a group of people, the risk and the vulnerability. So basically what we are saying is we are looking at the social and the legal and the other contextual factors that will increase their vulnerability to HIV and also obstruct access to HIV services. Key of these include the decriminalization of and the transmission of the key populations, and also looking at the laws to protect the rights of an individual, reducing stigma, of course, because stigma is also one of the key issues that will affect clients accessing HIV services, and also discrimination. We are also looking at or reflecting on the violence prevention and the response of the same, and most importantly, empowering the community so that they can be able to own their health and the leadership. The last intervention arm is the biomedical intervention, where we are looking at those that directly influence the biological systems through which the virus, once it enters the body, then it can gain access to the body cells. So we are looking at interventions that will block the virus transmission. We are looking at the male and female condoms. Other issues are decrease the infectiousness. That is through you've heard what my colleague said, U is equals to U. That is undetectable, is equals untransmittable. So we are looking at the use of ART in prevention. And then reducing the risk of acquiring infection. For instance, there is also a program in NASCOP that deals with VMMC and also STI management. So we have mentioned the number, looking at harm reduction for people who inject drugs, needle and syringe program, and then opioid substitution therapy or the MAT therapy. And then looking at HIV testing and counseling, we have seen that we are transiting to or shifting to the 3-test algorithm so that we match with what is our current prevalence. And also key is the STI prevention, screening and treatment, not forgetting the EMTCT and we have an RRI that is ongoing at the moment, TB screening, and of course, PrEP and PEP. So for today, we are going to look at one of the key biomedical interventions. Among the three, we are only looking at a portion of the biomedical, which is PrEP. So my colleague has talked of the whole person approach, and this is what we are going to look at. So I said, PrEP reduces the risk of transmission from sex by about 99%, and highly effective for HIV prevention. When we look at the different the methods that we have, we are looking at oral PrEP and also long-acting injectable PrEP and the KBLA and the dabivirin ring. For the daily oral PrEP, the preferred is the TDF FTC, though in some of the facilities, we are finding that some of our healthcare providers are using TDF 3TC. We would like to take this opportune time to request that we revert to TDF FTC, that is the 300 milligram, 200 milligram, as the fixed dose combination once daily, so that we leave the TDF 3TC. So the recommended or the preferred is the TDF FTC, and we will appreciate if we can take this home, that if we are dispensing TDF 3TC, then we have enough stocks of the FTC combination. So that is our key home message, take home message. And then we're also looking at, in the daily oral PrEP, we also have the other option of event-driven oral PrEP, which we are going to see in detail subsequent to this presentation. And then we also have the long-acting products, which include the KBLA and the dabivirin vaginal ring. The KBLA is an integrase inhibitor with over 79% effectiveness. That is from the studies that have been done. And it is for anyone who wants to prevent HIV during sex. And then we have the dabivirin vaginal ring, which is a flexible, one size fits all silicone vaginal ring, which slowly releases the ARV called dabivirin over the period of 1 month. And it is a woman-initiated HIV prevention method. The dabivirin ring was included as an additional prevention choice for women at substantial risk of HIV infection and approved by PPB in country in 2021. And the KBLA is awaiting approval by PPB for in-country use. And the two long-acting PrEP methods are at different stages of implementation studies, except, of course, for the KBLA, before we inform the country on when we can be able to start using the long-acting methods. So for now, we have the oral PrEP, which is for the general population, and we also have the event-driven PrEP for those assigned men. So for event-driven PrEP, it is also known as the on-demand PrEP or 2+1+1, then PrEP, or non-daily PrEP. Event-driven PrEP is where event, and an event here is a sexual act. And various studies that were conducted have shown effectiveness in prevention of HIV among people signed male at birth and no exogenous use of estradiol hormones or gender-affirming hormones. So before we offer PrEP, or basically PrEP is not just the commodity that is dispensed. There is a package that we can say all put together will indicate the effectiveness or the success of a PrEP program, because it's not just about dispensing, but also being able to monitor to know that whatever we are dispensing or whatever methods we are dispensing to our clients, we are able to follow through to ensure that they are effective. One of the things that we have to do critical is screening for HIV risk. And then we're also looking at management or screening for STIs, because we all know that with STIs, there is a greater, because you are exposed to acquiring HIV. We're also looking at gender-based violence in that client of ours who comes to the facility seeking service, because we may be able to administer the PrEP, but what will be the thoughts around the partner when he or she sees issues around the client taking PrEP? So those are the perceptions that we also want to learn from our client on whether he or she will freely be able to take the PrEP. Because if you are not able to be supported by your partner, then even the effectiveness of the method will not be successful. We also look at screening for alcohol and drug use, for possible interactions of alcohol and drugs with the commodity, and also determination of eligibility for PrEP, counseling and client education, and also prescription of the event-driven PrEP and follow-up, and also referral and linkages for any appropriate service after that. Because we are looking at combination prevention and issues around integration, we are not just dispensing the biomedical component, but we will also look or assess which other interventions of the combination preventions that our client can qualify. And if he so qualifies for other services such as VMNC, please do not miss that opportunity to refer the client appropriately. We also do the risk assessment before initiation of PrEP. And this is done by a tool that has been developed by the program, National AIDS and STI Control Program, and commonly referred to as the PrEP RAST. RAST standing for Rapid Assessment Screening Tool. And so it is used as a screening tool to identify clients at risk of contracting HIV. And this will inform the PrEP referrals. Because we are talking of integration of services, we are looking at the tool being administered at any of the HIV testing points. I can see that one of our attendees has asked about the increase of testing and also the decrease of the positivity rate. Because we have integrated PrEP services at various service delivery points.
Excuse a bit, Doc.
Yes.
Yeah, there's some kind of background noise from your side. So we are getting some echoes, so I don't know.
Sorry for that.
Okay, you can continue.
Yes, thank you. Sorry for that. The RAST tool that may administer the various testing points because of the integration of services. It can be administered either the CCC, MCH, OPD, and even at the community level. And a yes response to any of the screening questions indicates substantial ongoing risk of HIV infection. Some of the questions that are contained in the rapid assessment screening tool, as you may see, is around what is your HIV status and what is the HIV status of your sexual partner? And in the past 6 months, have you engaged in transactional sex or sex without condom? And there's a series of around 8 questions. And we've said a yes response to any of those screening questions, then it indicates substantial ongoing risk of HIV infection. And those are some of the risk assessment screening questions that we are taking our clients through. And most of the screening questions refer to the past 6 months and include having sex with more than one person, or knowledge of having sex with a person who has HIV, or even have you been forced to have sex against your will? Have you been physically assaulted, including assault by a sexual partner? And also, looking at the discordant couples, we are also interested in to know whether they desire to get pregnant, and also what is the viral load level of their partner. So those are some of the questions that we take our clients through before we initiate them on PrEP. Then after that, we can proceed to discuss with our clients on the various interventions, various combination prevention interventions, the biomedical, and also all the structural and the other one that we talked about. And then the clinician will evaluate to determine the eligibility and suitability to use event-driven PrEP, or offer other appropriate referral for other services that we've talked about, such as the harm reduction, or the needle syringe program, or even the VMMC. Who is eligible for PrEP? PrEP, as we've alluded, eligibility for event-driven PrEP. Eligibility is determined using the clinical encounter form. And for those who have interacted with our PrEP toolkit and the PrEP framework, you can be able to get this clinical encounter form at the back of those documents, and you can be able to refer to them. And then also, the clients initiating the event-driven PrEP are supposed to meet all the following criteria. One, it has to be a client who has been confirmed HIV negative status using the RTK, or the rapid antibody tests, following the algorithm on the day of the initiation of the PrEP. And then we also have to determine whether our client has an acute acute symptoms, those could be consistent with acute HIV infection. And then for those clients who have no contraindication to use of any of the ARVs molecules such as TDF or emtricitabine or 3TC for those who choose oral PrEP. And we have already sent out a circular urging you all to revert back to TDF, FTC, and stop using 3TC. And then we also have to assess for any renal or liver disease for the clearance of the drugs from the systems. So clients with the renal or liver disease should receive further clinical and laboratory tests to determine the extent of the disease and or the renal or the function, so that we are able to ascertain the clearance of the drugs from the system. We'll also determine eligibility for event-driven PrEP if there is no hepatitis B infection. We have talked of 2-1-1 dosage, and this is what makes it unique from the oral PrEP, because for it to be effective or to achieve a high level concentration initially, and then we continue with the other dosing, then the dosing has to be followed strictly so that we have 2 pills, 2 to 24 hours before an event, where you take 2 pills. And then after the event, you can take 1 pill 24 hours after the first 2 pills. And we are saying 24 hours because you may have taken it either 2 or 4 hours before the event. So you start counting 24 hours after the ingestion of those first 2 pills. And then after that, you'll take another pill 24 hours after the 3rd pill. And if sex continues on subsequent days, for example, you're planning for a 1-day event, then that would be the scenario. But in an event or likelihood that the sexual event takes a little more days than you thought of, then at that point, you are advised, or you advise the client to take 1 pill each day until 2 days after the last sexual encounter. So for example, if the last event was on a Monday, then you can take for 2 more days after the last encounter, which will be around Thursday. The follow-up plan after the event-driven prescription is you have offered PrEP and you have discussed the dosing options with the clients, and the client has acknowledged that he has got adequate information, then you can be able to follow up the visit 1 month after initiation and or every 3 months, whereby when the client comes, you can be able to provide an HIV testing and screening for STIs, because when you are administering the PrEP, it is knowledge that you also advise the client that PrEP is just to prevent HIV acquiring. But for us, or for the client to prevent himself against STIs, then he has to do the use of the condom. So at that point, when there is a follow-up visit, we have to do HIV test and also screen for STIs. And then secondly, we continue offering the counseling by discussing the adherence dosing strategy during use, and if the PrEP user transitions from one dosing strategy to another. And also we are looking at the client. Will the client be wishing to change from event-driven to oral PrEP? So that is the time in which we are able to ascertain that based on the information you get from the client, then you can be able to counsel him appropriately. For instance, if you realize that he has been extending the events and he has been continuing to take the drug more frequently than just one event, then at that point you may, or you are at a point to discuss with the client and advise him to change either to oral PrEP. Thirdly, assess if HIV risk is likely to persist in the next few weeks and months. And if the risk is going to stop, then you can be able to stop the PrEP prescription. And then, if possible, you also may require more active support in continuing PrEP, whichever dosing strategy is chosen. PrEP is not prescribed for the cisgender women or transgender women. Cisgender women, meaning those who are taking gender-affirming drugs to become women, or the transgender women, those who are taking drugs to become men, and also people with chronic hepatitis B infection. As we have discussed earlier, is that there are two options. We can either prescribe the daily oral PrEP, or we can also prescribe the event-driven PrEP. And as we have seen earlier, is that the daily dosing is appropriate for those whose occurrence of sex cannot be predicted. It's an event. It's a one-day event, so they can be able to take it. But for those who are going to have a longer period of exposure to HIV, then you can prescribe them oral PrEP. And then it is also appropriate for the daily dosing is appropriate for those whose potential exposure to HIV are more frequent than 2 times per week, where you find that using the event-driven they would have to take it so frequently that it would effectively resemble the daily PrEP. And that is what we've discussed and said for them. Once you discuss with him and you realize that he's taking the event-driven daily, then you have an opportunity to convert that to daily PrEP. A man using the event-driven PrEP can stay protected by taking another pill each day, that we say, and you can stop 2 days after the last event. Among the key counseling messages that we have to provide to our clients include explaining comprehensively the purpose of event-driven PrEP, that it is only for the prevention of HIV and it cannot prevent pregnancies, it cannot prevent STIs. And also discuss with our client the importance of taking the medication as prescribed, following the 24 hours after the first and after the first 2 pills, and then 24 hours after the third pill. So we have to discuss with them the importance of adhering, because that will increase the efficacy or effectiveness of the PrEP molecule. And then also discuss with them that when they start taking PrEP, then they're likely to have gastrointestinal symptoms such as diarrhea, nausea, and any other side effect, and that they should not stop taking the PrEP once they start experiencing those side effects, and assure the client that those are temporary and they will be fading away with time. Discuss also the potential drug-drug interactions and also with them, so that if you can get it from them, whether they are taking or they are on any other medication, and discuss with them that there is potential that the effectiveness of the PrEP might be reduced because of the drug-drug interactions. And key importantly, discuss the use of condoms, so that we are looking at this person, the all-person approach, so that we are also preventing other conditions such as the STIs. Discuss the importance of routine testing, so that after every 3 months, the client is eligible for testing for success of the PrEP method used before administering another prescription. And then, of course, provide support and follow-up. Always be available to answer the concerns of our clients if they experience any of the issues that will arise as they are taking the PrEP product. I think we have looked at the issues around before or around the client preparation. We have looked at ensuring that you give informed, or rather you give adequate information for the client to be at a position to take the medicine as and when is required. Be aware of the potential side effects and the continuation to use other combination prevention such as condoms, and then the scheduling of the regular follow-up appointments for retesting or confirmation of the HIV status. And if you find that in some of the follow-up appointments, when our client turns HIV positive, then at that point we stop the PrEP and refer the client for appropriate management. Event-driven PrEP can be discontinued if at any point the client risk changes from an ongoing risk, and at that particular time there's no risk. For example, if a female sex worker or MSM has stopped practicing, and then there's no risk, then at that point you can be able to stop, discontinue event-driven PrEP. And also the client comes to you and requests that I would wish to stop. It will also be good to discontinue event-driven PrEP, but be able to discuss with the client of the other available methods, and also indicate or note down the reason of or why the client wants to stop. And in the course of discussion, you realize that the client does not adhere to the timings of the drug, then you can be able to also discontinue the PrEP. Then also change in the individual's medical status, because we have said we have to assess the renal and the liver functions, and also diagnosis of hepatitis B. And also lastly, any test that will indicate our client is HIV positive, then we also discontinue PrEP. Take-home message is that event-driven PrEP is highly effective among individuals assigned male at birth and are not taking any hormones, gender-affirming hormones, and are at risk of HIV infection. Event-driven PrEP involves taking a higher dosage of PrEP medication 2 to 4 hours before the event, and then followed by a tablet 24 hours after the 2 pills, and then 48 hours after the initial dose, or 24 hours after the 3rd pill. And then effectiveness has been shown to be up to about 97% if taken as advised by you, the healthcare worker. And event-driven PrEP may be more convenient and cost-effective for those individuals who have infrequent or unpredictable sexual activity compared to where a client has to take the daily oral PrEP. Thank you so much. Back to you, Kennedy.
Thank you very much, Dr. Jonah. I think that has been one of the wonderful presentations from you and Dr. Oyugi. So I'll just go through some of the questions that have been posted. I haven't seen Dr. Nafula joining us yet, so we are not able to to see, but we wait if she'll join us for us to close the meeting. Great. So I'll go straight to some of the questions that have been posted, and either of you can take up. We have, how long does it take for a vaginal ring to be effective?
Thank you for that question. What I can say is that though it was approved for use in country in 2021, the WV vaginal ring, we are still in the implementation studies, and hopefully by then we'll be able to ascertain in the Kenyan scenario how long it takes for it to be effective. And also there are other studies that will also inform if you want to change the PrEP method, how long you should take if you want to change, for example, from oral to the WV ring, how long should be able to take, or at what point do you start using the WV ring before you switch off from the other method? So for now, what I can say is we are still in the implementation studies, and we'll be able to answer that in the future as time comes by. Thank you.
Great. Thank you very much.
I could add.
Yes, Dr. Yugi, go ahead.
Yes, so the WV ring, we are already having women who are on the WV ring, and the advice that they're given is that once the ring is inserted, then they should at least be off sexual contact, especially for the first 48 hours. After that, then we are sure that they can be protected, because the ring is impregnated with the PV ring, so it takes a bit of time to to release that into the vaginal environment. So at least 48 hours. Thank you.
Okay. Thank you very much, Doc. So there's an interesting question here that any updates on HIV self-tests? Currently, where are we? Maybe Dr. Yugi, I can give you this to answer.
Actually, I would like to invite Dr. Jonah to comment on that.
Okay, Dr. Jonah, take it up.
Is there any update on HIV self-tests? Okay, maybe it's incomplete, but in the context of PrEP initiation, or maybe I would like to get it clear. But if it is in the context of PrEP initiation, then what we can say is that we, as a country at the moment, we are not at a position of initiating PrEP by HIV self-test or monitoring the same, but we are following keenly the WHO guidelines on what they have said in terms of using the blood-based HIV self-test to initiate a PrEP. And we may be able to come up with a position as a program at a later time and be able to advise. And of course, we'll also communicate the same and discuss the same through the technical working group before we give guidance. Thank you.
Okay, thank you very much. What will be your take on PrEP interaction with oral hormone contraceptives? Your advice to the clients? Either of you can answer this.
Yeah,
Yes,
yes.
you
So,
go ahead.
yes, we don't have any documented interactions, for PrEP and antibiotics or contraceptives. Currently, what is being researched is around delivery of both, PrEP an active molecule for PrEP and contraceptive within the same method. So, for example, a dapivirine ring, a ring that has both dapivirine for PrEP and a contraceptive, so that the woman does not insert the ring and then take another contraception. So there's no documented interaction. I've seen those questions around antibiotics and the contraception. Thank you.
Great, thank you. Because I know that many times people tend to maybe have confusion that there is any linkage, but I think that's well understood. I came across this trial, that is CARES, cabotegravir and rilpinavir, efficacy and safety study, trial in sub-Saharan Africa, that is Kenya, Aga Khan, KNH and MTRH, Uganda and South Africa. Any updates about the same?
So the studies that were done were around the PrEP, right? So cabotegravir, cabotegravir is it's an ART that we are currently using as an injectable, but in Kenya it's not been authorized for use. So there was the question around use of injectable HIV, injectable HIV treatment. So that's why I'd already written there that there are studies, especially there are studies, of course, that were done even in other parts of Africa, and there are pilots that have been done in Europe. Yeah, so as at now, we don't have any information around injectable HIV for treatment. What we have is injectable ART for prevention. So that is the study for cabotegravir and rilpivirine. Thank you.
Great, thank you. So there's this question here, maybe this concerns the patient navigation program and maybe some of the support. Like many clients on PrEP are having difficulties paying for their creatinine test. Is there a way the clients can be supported on this? Maybe, Doc, is there any programs currently ongoing that support such patients?
So, Dr. John, maybe you could chime into that.
Thank you. There could be other donor-supported programs, but for now, what we can say is with NHIF, the client should be able to use the NHIF card to be able to access some of these laboratory services. I don't think, or it has not come to attention that there are clients who are not able to do the creatinine because they cannot afford, because with NHIF, then our clients should be able to afford some of these lab services. And we are encouraging all our clients to register with national health insurances that are available so that we can be able to utilize them to access some of these services. Thank you.
Thank you very much, Doc. And I totally agree that now it's high time that maybe all our clients, if it is better, to be registered by insurance cover, because this will be able to help them in the burden. Oh, great. So I hope you will not mind. There are some good questions here, so I hope maybe you'll be a little bit patient as we are preparing to end the session. Hi, these programs for HIV 3 phases testing can be rendered at community pharmacies in collaboration with government in reporting on HIV reporting tools. I know Dr. Yugi has said that training hasn't been rolled up again, but can it happen, Doc?
I've been trying to understand that question. So I was trying to understand what is the question asking.
Okay, I think maybe the person asking about the community pharmacy. Maybe most probably you find many times we have chemists and pharmacies within the community level. That can they be able to allowed to conduct this test?
So there are a lot of policy issues around HIV testing. Probably you are aware that there's been a court case
Yes,
surrounding around the HIV testing. So these are issues that we cannot conclusively provide a response to right now with regards to testing in those community pharmacies and and chemists. But
yeah,
as part of as we move towards universal health coverage, then of course we need to improve access to testing services, and as we move towards status neutral testing, and I think one of the strategies that we are employing is the community index testing. But for now, we are basically using more of the referral mechanism. So that's
yes.
what we're using as at now. Yes. So that's all I can say about that. Thank you.
Great, great. Great. My question regard the time lapse, that is 2 weeks and 3 months for retesting inconclusive results. Do we stand a chance of losing these clients? Any preventative measures in the meantime as they await retest?
Then, so this is an issue that has been raised several times. In fact, one of the issues that has been raised has been around the number of pricks. I was actually expecting that to also come up. So what we need to understand is that our positivity rate is roughly 1.8% to 2%. So we are not going to probably do all the three tests on each and every person that gets a HIV test. So for those, again, with inconclusive results, they are it's a very a small percentage. And these are clients that we should be able to do what's called continuous engagement, offer counseling services, and be able to trace them to ensure that they come back at 14 weeks. The risk that we have is that these clients will hop from one facility to the next to try to test, and hopeful that they can get a different result. And that's why we'll be able to assign a personal identifier so that we can also be able to track everyone that accesses the testing services. So with regards to the DNA PCR, so the WHO recommends that for inconclusive results, currently, once you move to the 3-test algorithm with more than 99% PPV, then DNA PCR is no longer useful. So we'll basically be, sort of wasting resources. So once the person comes at 14 weeks inconclusive, then they come back after 3 months. If it's still inconclusive, then they're supposed to be labeled as negative. Thank you.
Thank you. I think that one also you've been able to answer a question that was also looking at the DNA PCR. I think you've been able to highlight that very well. There's also what accounts for the lack of effectiveness of ED PrEP for women?
Dr. Jonah?
Dr. Jonah, maybe you can take this up.
Thank you. From the studies that have been done, I think, and that is what we scientifically rely on, thanks Celestine for asking that, is that event-driven PrEP generally is effective for all male, and especially male who are assigned the gender at birth and are not on any estradiol, exogenous estradiol hormones. So for now, what we can say, partly because of those hormones, then it cannot be effective among the women. So it is basically indicated for male. I know there are studies that are ongoing to see whether even among the women, whether it can work. But for now, we don't have adequate studies to inform that. So those are the studies that we have around the male population and use of that method among that population. Thank you.
Okay, I'm just about to let you people go so that I don't keep you waiting here. Maybe some 1-2 questions, then now we can have a closing remark. In some cases of either oral sex and anal sex, can PrEP still prevent me from getting HIV under the same doses? Very interesting question there, Dr. Oyugi and Jonah.
The answer is yes, because PrEP is actually recommended very highly among key populations, men who have sex with men, who have anal sex, of course. Oral sex has even lower risk of HIV transmission than vaginal sex. So PrEP is recommended for all. Yes, it's very protective, as long as the client adheres. So if it is daily oral PrEP, it's daily oral PrEP.
Okay. I could see questions surrounding the issue of PrEP register. Are they still in use?
Jonah?
Yes, thank you, Kerry, for that. The PrEP register, we have been able to revise the registers, or rather the M&E tools, and the tools that will be launched, or the tools that will be printed and redistributed, will be having a section where we can be able to differentiate those who are on PrEP versus those who are on the event or the event-driven PrEP. And the new tools also have a section where you can also record why you are actually stopping the PrEP or discontinuing PrEP. Thank you. The new version.
Great. Thank you very much, Dr. Elvis and Dr. John. I think you've been able to answer majority of the questions. Maybe I would like to have Dr. Oyugi and Dr. Jonah maybe give a closing remark, considering our chair is not here today.
Dr. Jonah?
Let's start with Dr. Oyugi. Yes. Oh, we start with Dr. Jonah. Yes, yes.
I give this opportunity to thank all of us. I wish to take the opportunity to thank all of us, because achieving epidemic control is an honor to all of us, right from the facility level, policymakers, and even up to the community level. So we are more than happy to have these, or rather to have been invited to share this information to all of us, and we look forward to more interactions. And also we invite your participation at various technical working groups, so that we can be able to share more of this research that is coming in, and also on new findings, because as you realize, with advancement of technology, there is always a lot of information coming in minute by minute. And for us to adapt at that high speed, we need each and everyone else on board. Otherwise, thank you so much for this opportunity, and I pass it on to my colleague, Dr. Oyugi, to wrap it up. Thank you.
Thank you very much, Dr. Jonah. It's been a pleasure presenting in these webinars. Very, very informative. The truth of the matter is that PrEP is very effective prevention method, and as a country, we really need to embrace it, adopt it. It actually is a game changer when it comes to HIV programming. We have challenges, especially with those who are enrolled, dropping out, issues around adherence. And we are hopeful that once we have the long-acting agents, especially the cabotegravir, once that is authorized for use within the country, then we can solve the issue of adherence, because the issue of adherence comes about due to the fact that you have to take a daily dose of PrEP. As a program, again, we are really embracing new interventions, embracing technology, revising our tools to ensure that we are current, and we are also able to cater for the needs of our people. So otherwise, thank you very much. And whenever there's need for us to provide any information, be it with, as a webinar or any other format, we are very ready. And I've seen a lot of requests to share the slides. So probably we can be guided by the admin. We can share with the admin, and then it's shared with all the participants, so that they can all get this presentation. Otherwise, thank you very much, and I really appreciate the moderation by Kennedy Okinda. Thank you very much, everyone. And bye bye.
Thank you. Thank you very much, Dr. Elvis Oyugi. Looking forward to meeting you one day, and also Dr. Jonah for this. I want to take this opportunity again to appreciate you taking time to take us through this. And as you all know, like we've come a long way in matters HIV, and I'm so glad that we are still making progress. Several studies are coming up, and I think this is a platform that we'll still continue to use to make sure that a bigger population are able to get the information. I would also like to thank our participants. We've hit around 750 attendees, and that is quite good number. And I'm so glad that you've been able to tackle some of the questions they have. I think this is just a discussion that we should not have it for a one day. We need to have periodic sessions, so that we can be able to have full dissemination. So from my end, I also want to thank the participants, all the panelists, our sponsors, that is Philips, Janet Handa. Maybe if you have anything to add before we close. I said that I should not lock you out.
Thank you very much to our presenters. We really appreciate the information that you have shared, to the country for all the hard work across board, from the implementing partners, all the doctors, the healthcare professionals, the community itself, whose theme it is for today's World AIDS Day, Let Communities Lead. We appreciate, and it is good to see that we are achieving the levels and adopting and moving forward well. So from our end, from Philips and Gilead, we continue to work together to support where we can, and just to see how we can make good progress in our country. So thank you all very much. Have a good World AIDS Day, and enjoy the rest of your month. Thank you.
All right. Thank you all for the slides. We've recorded the sessions, and we'll still be able, if we get the presentation from our colleagues, we'll be able to share. And still, you can check out even our YouTube channel for the recording, because we link the webinars to the YouTube channel, so you can be able also to follow up and get the information back. Otherwise, thank you very much from my end. I'm Kennedy Okinda from Mwai Kibaki Hospital in Nyeri. I was your moderator for today, and thank you, and have a lovely evening and weekend ahead. All the best. Thank you all.
Thank you very much.
Thank you, Kennedy, and everyone. Nice day.